Ashley Aguilar,
And my name is Chelsea.
and our presentation is over oxygen therapy and hypoxemia. So our objectives for today are to define hypoxemia, go over the indications and the goals for oxygen therapy, provide an overview of low flow and high flow devices. We'll go over some risks and factors to consider when you're selecting your oxygen devices. We'll identify oxygen therapy devices for children, and we will discuss guidelines regarding oxygen therapy and hypoxemia. All right, so what's the difference between hypoxemia and hypoxia? Hypoxemia is low oxygen in the blood, whereas hypoxia is insufficient oxygen that's delivered to the tissues. So in situations where there is too little oxygen in the blood, hypoxemia, it can lead to cellular oxygen deficiency, which is your hypoxia. We can use the AA gradient to help determine causes of hypoxemia. So the definition is it measures the difference between O2 concentrations in the alveoli and arterial system and can help determine the cause of hypoxemia. So it's P big AO2 minus P little AO2. So your big A is your alveolar oxygen tension, and your little a is your arterial oxygen tension. And down here, I have a little chart. And so I listed some causes of hypoxemia and the effects of the AA difference. So with a VQ mismatch, you would expect an increase in your AA difference. With a shunt, you would also expect an increase. And with alveolar hypoventilation, it would be normal. Some indications for oxygen therapy. So oxygen therapy is indicated in treating patients with hypoxemia and oxygen saturations below the target saturation range. For patients at risk, oxygen therapy should be started when stats are less than or equal to 88% and stopped when it is 92% or greater than 92%. For patients without risk factors, oxygen therapy should be started when SATs are less than or equal to 92% and stopped when it's greater than 96%. Another indication is arterial blood gases. They should be obtained in patients who are critically ill and when a pulse ox reading can't be obtained or when hypercapnia is suspected. So some clinical indications for oxygen therapy. The easiest is a patient assessment. So you'll assess their color, see if there's any signs of cyanosis, any changes in their respiratory rate, like see if they're tachypnic, an increased work of breathing. You look and see if they're using any accessory muscles, change in their arterial blood oxygen, and then change in their stats, measured in their blood gas, or their SpO2 on a pulse ox. Oops. Goals for oxygen therapy. So the goals are to increase alveolar oxygen tension, try to correct hypoxemia, decrease your work of breathing, decrease myocardia workload, and to get adequate tissue oxygenation. So for your oxygen devices, there are tons out there. We just listed a few. So for your variable devices, you have a nasal cannula, a simple mask, partial rebreather, non-rebreather, and for your fixed performances, we have Vini mask, aerosol trait collars, and high flow nasal cannulas. And so the choice of treatment is based on your FiO2, your PaO2, your current respiratory support, and overall clinical state of the patient. For your oxygen devices, we on the right over here, there's a picture of different devices. And then I have the device like a cannula. The FiO2 ranges from 24 to 35% at a flow of 1 to 4 liters. It's very comfortable, easy to titrate, and it's not expensive. Simple mask. The FiO2 ranges from 40 to 60% at a flow of or a flow greater than 5 liters per minute. And then the delivery of higher FiO2s levels than a regular cannula. With a non-rebreather, you can give greater than 60% FiO2 at a flow of 15 liters per minute. So you're able to give that higher FiO2 than with a simple mask. With a Vini mask, the FiO2 is set from 24% to 60%. And the advantages are you have a controlled FiO2, and particularly at 24 to 28% in patients with COPD and others at risk at hypercapnic respiratory failure. And then the high flow cannula, your FiO2 can range from 21 to 80%. It's comfortable, it has humidification, it's really easy to titrate across a wide range of FiO2. And down here it just has what FiO2 means, fraction of inspired oxygen. And then obviously we know what COPD is. Let's see. So your low flow, you would go with a low flow device when your sats are less than 92%, and on your blood gas it's less than 80% PaO2. If you have an increased work of breathing, chest pain, or if you're tachycardic. So now we're going to go into the oxygen devices more in depth. So we will go over the high flow nasal cannula, our non-invasive ventilation, and then we'll go into the mechanical ventilation.
So some indications for high flow nasal cannulas: SATs less than 80% or a PaO2 of less than 50%. If your patient's having respiratory distress, if they have hypercapnia, when your patient is needing a more precise FiO2. Also, we will start high flow to prevent escalation to invasive mechanical ventilation, and then also to if they have an intolerance to a non-invasive mask. So some contraindications for high flow are central apnea, if a patient has a pneumothorax, nasopharynx surgery or trauma, and then upper airway obstruction. And this is a little chart showing the mechanism of action. So it spells out high flow. So for the H, we have heated and humidified. As you know, the high flow nasal cannulas provide heated and humidified gas for our patients. The inspiratory demands, it can better meet elevated peak inspiratory flows. So high flow nasal cannula devices can go up to 60 liters. For the F, it's functional residual capacity, so it increases FRC likely via the delivery of PEEP. For the L, it's lighter. It's more easily tolerable than a CPAP or BiPAP compared to those full face mask and the other masks that are used for the BiPAPs or CPAPs. The high flow nasal cannula is much more tolerable for the patients. Oxygen dilution, it can minimize oxygen dilution by meeting flow demands. And then our W is washout of dead space. It provides high flow rates leading to washout of pharyngeal dead space, so CO2 removal. So moving on to invasive ventilation, when high flow nasal cannula and non-invasive ventilation fail to help the patient with their hypoxemia, um, invasive ventilation is what we do. So indications for that are continuous decrease in oxygenation, an increase in arterial CO2, when the patient has persistent acidosis, and then, of course, respiratory failure. And then for non-invasive ventilation, so non-invasive ventilation, it provides the delivery of positive pressure ventilation through a non-invasive interface, which is usually a mask. Some modes of NIV include CPAP, BiPAP, and then AVAPs. Um, and the aims for NIV is to correct gas exchange and relieve the increased work of breathing to avoid invasive mechanical ventilation. So moving on to children, oxygen therapy in children. So there's multiple devices. Some include blow-by oxygen, the Oxy Hood, low flow nasal cannula, high flow nasal cannula, bubble CPAP or CPAP, and then of course mechanical ventilation. So here we have a table, and it goes through each different interface, and it provides an FiO2 range and then the indication. So for blow by, the indication is a low dose and patient does not tolerate a mask, but it does provide inconsistent delivery and must monitor your oxygen saturation. For a nasal cannula, it is a low dose, but it is affected by changes in the baby's inspiratory flow. And then you have your high flow nasal cannula, which can deliver low to high doses. And it is affected by changes in inspiratory and expiratory flow, and it requires heat and humidification. Then we have our simple, partial and non-rebreather mask. Our oxy mask as well, it provides a low to high dose and requires proper positioning of the patient. You have your hood or tent, and then you have your manual resuscitators, and then mechanical ventilation. So some adverse effects of oxygen therapy in children. So oxidative stress. Oxidative stress is a imbalance between pro-oxidant and antioxidant forces in the body. The role of oxygen in oxidative stress is a huge development in a number of neonatal diseases. Oxygen is toxic because of the production of reactive oxygen species. Therefore, oxygen administration increases oxidative stress. Retinopathy of prematurity, ROP. This is a neonatal disease that is characterized by abnormal vascularization of the retina, causing a range of vision impairment, including blindness. And then lastly, chronic lung disease. Oxygen administration was identified as a risk factor in the development of neonatal chronic lung disease in early descriptions of bronchopulmonary dysplasia. So some factors to consider for oxygen therapy. We need to make sure that we consider the patient's past and current medical history. An example for that is our COPD patients. They require lower concentrations of oxygen due to their target oxygen saturation range, which is 88 to 92%. And so that we need to make sure that we give them the right amount of oxygen due to their sensitivity to it, and also other patients who may be very sensitive to oxygen therapy. For long-term oxygen therapy, it is an established therapeutic measure for patients with chronic hypoxemia. Causes for long-term oxygen therapy are diseases such as COPD, idiopathic pulmonary fibrosis, and pulmonary vascular disease, and also COVID-19. The aims of long-term oxygen therapy are to improve quality of life and performance, as well as to reduce morbidity and mortality in our patients. So some other complications of oxygen include loss of hypoxic drive and then oxygen toxicity. So with patients with chronic lung disease who have CO2 retention for some time, have respiratory centers in the brain that are stimulated by a reduced arterial oxygen therapy. Administration of oxygen above 24% may limit their hypoxic drive and lead to further CO2 retention. And then also the use of fixed performance devices are essential when treating COPD patients to reduce the risk of hypercapnia. For oxygen toxicity, it can result in decreased mucociliary transport, atelectasis, inflammation, pulmonary edema, and eventually interstitial fibrosis. So the hyperbaric chamber, it is a treatment for CO2 poisoning. It is commonly treated by breathing high concentrations of oxygen. 100% of oxygen helps improve the dissociation of the carbon monoxide from the hemoglobin, and its half-life is improved by hyperbaric oxygen therapy. So lastly is the AARC guidelines for oxygen therapy. They provided recommendations that we'll go over. So first one, providing supplemental oxygen to patients in critical care environment is essential to the management of hypoxemia. Treatment of hypoxemic respiratory failure with high-flow nasal cannula may avoid escalation to NIV and reduce the need for intubation in patients, particularly with PaO2, FiO2 less than or equal to 200, and immediately post-extubation when compared to conventional oxygen therapy. It is recommended for high-flow nasal cannula over conventional oxygen therapy for hypoxemic respiratory failure, and a conditional recommendation for use of immediately post-op in cardiac and or thoracic surgery patients. It is recommended to add humidification to reduce discomfort associated with supplemental oxygen flows greater than 4 liters. And then lastly, we have oxygen saturation ranges that they provided and recommended. So patients who are requiring oxygen, their sat range will be 94 to 98%, and their PaO2 range will be 70 to 100. Patients with COPD requiring oxygen, their range is 88 to 92%, and their PaO2 range will be 55 to 75. And then patients requiring FiO2 of greater than or equal to 70%, their SAT range will be 88 to 93%, and their PaO2 range will be 55 to 80. And this concludes our presentation over oxygen therapy in hypoxemia. Thank you.